So good morning, everyone. Because for us it's morning here in Southern California. We're sending this journal club from the University of California, Irvine. And I want to welcome all of you to the journal club of the European Journal of Cardiovascular Nursing. And mostly I want to welcome our first author of the paper that we're going to discuss today, Professor Lorraine Evangelista.
Hello, everyone.
That is a professor of nursing science here at the University of California, Irvine. And I'm Anna Stromberg. I'm a professor of nursing science at Linköping University, but right now I'm a visiting professor at the University of California, Irvine. So the paper we're going to discuss today was published in 2014 in the European Journal of Cardiovascular Nursing. And it's entitled Ongoing Palliative Care Enhances Perceived Control and Patient Activation and Reduces Symptom Distress in Patients with Symptomatic Heart Failure, a pilot study. And Professor Evangelista is an expert in this area of expertise of doing research in palliative care in heart failure. So it's going to be interesting to discuss this paper with you. And I would just like to start by giving the word to you to give us a little bit of background to why and how you conducted this study.
Okay, thank you so much, Anna. Hello, everyone. So actually, the start of this study, it was not planned to be a research study. So we didn't plan to do a research study, but what was happening was there was a change in practice that was going to take place at UCLA where I was at that time. So in the early 2000s, palliative care services wanted to try to develop a model of integrating palliative care with heart failure care, which is the similar model that we have for oncology. So they agreed to see our heart failure patients following discharge from acute decompensation at the same time that they came back to see their heart failure specialist. So the study was conducted in an attempt to try to see whether there were going to be better outcomes in these patients that were now getting managed by both heart failure specialists and by the palliative care services. So we just kind of wanted to be able to document or report on outcomes, whether they were going to be positive or negative, so that we can show the hospital administration that it was worth putting money into.
Yeah, I think that's a good way of doing clinical research, that you actually are on top of things and evaluating what you're doing already from the start, because I think it's often the other way around, that you start up services and then when the questions are asked by the administration, what are the outcomes, you don't have any data. So the data was developed at the specialist center.
So it was still in the heart failures. It was in the heart failure clinic, and at UCLA, the heart failure clinic there is a tertiary care center, which means it's a heart transplant center. And so we actually get patients from across the nation here in the United States coming there because they're referred for heart transplantations. So this is where we actually were enrolling patients, and that's where they were getting their palliative care treatment as well. Because what would happen is that during a heart failure clinic, scheduled clinic, the palliative care specialist would also come and occupy one of the clinic areas to see the patients after they were seen by their heart failure specialist.
So it was like a joint multidisciplinary team visit that
yes,
the patients received.
Was.
Yeah. And can you say anything about the sample? Because it struck me that the sample was fairly young and predominantly white males that were married.
Yes.
So how representative would you say that population is for the U.S. and how does that affect your generalizability of your pilot studies?
In terms of its generalization, compared to the heart failure population in the US, it's a fairly young population. Most of the average age for heart failure in the US is mid-70s. And because the average age here was in the mid-50s, so it's definitely not representative of the general heart failure population. However, it is representative of the heart transplant population. So we can generalize more to them, I think, than to the overall older heart failure general population.
Yeah. And just a little bit by speculation, do you think it is a huge difference depending on age? Because
yes, and I would agree with that. We're actually trying to replicate the study in a more controlled design. And I say controlled because when we did this study, we had no influence on the intervention itself. So the intervention was planned before the researchers even decided on doing the surveys. So pretty much nothing was manipulated on our end as researchers. So what we're doing right now is we're trying to utilize similar questionnaires, utilize the same approach, but now I'm working with a team of heart palliative care and heart failure specialists here at UC Irvine to kind of also track and closely monitor exactly what services we are providing to the patients.
I think that's an interesting follow-up study to this study. So just to clarify, because that was one of the things I thought about when I read the paper, that it's so the groups that you had in the study were actually, that was not decided on beforehand, but you saw like depending on how many consultations or if no consultation, the groups were formed then.
Yes, and that's correct. So basically, all the patients that were hospitalized for heart failure decompensation were approached before they were discharged to advise them of the availability of the palliative care services. So at that same time, we also, as researchers, approached them about participating in the research study. So they completed questionnaires before they were discharged. Now you'll notice in the number of, so we consented 42 patients, but of the 42, there were people who opted not to even come for the palliative care services. So 6 people did not bother to come. They felt they didn't need it. And so because we had questionnaires from them, we included them in the comparison group. And like you were saying, Anna, we didn't decide ahead of time who would go in what group. We kind of just divided the groups based on the number of palliative care visits that they had, you know, within that 3-month period.
Yeah. So of course, like when you're looking at your table, they seem not to differ that much in demographics, the two groups.
They didn't, that's correct.
But one could speculate whether there were other things like denial or depression or other variables where they might have differed.
And I think so. And I think that's, you know, that's kind of one of the limitations of the study is the people that do volunteer are more likely biased towards even towards having less symptoms or being more, you know, having more control in their lives. So right away, there's that limitation in this type of study design.
Yeah, I agree with you. When you invited the patients to the study, there were a few people that declined at that time as well, but not as many. I think you had 15% that declined. Do you think they were also different from the ones that actually decided to participate in the study?
Because we weren't able to obtain consent from them, we were not allowed to collect any of the personal health information from them. So there wasn't a way for us to compare them with the sample that did consents. But based on, at that time, because I was one of the clinicians at UCLA, based on just knowing and anecdotally working with the group, I think it was pretty much comparable.
Mm-hmm. Yeah. Yeah, and if you look at the reasons why they're not participating, it's time and living too far. That is kind of half of the group's reason for declining. So
Yes.
That may be some more practical aspects why they decline.
Yes, and it's especially because it is a younger population. They are still mostly employed.
Yeah.
So they don't want to take the day off to come and, they'll come for their heart failure specialist, but the quicker they can get out of the clinic, the better. They're not going to want to spend another hour with someone else.
Yeah. And you kind of already discussed that with us, why you selected the design you selected, because obviously it would have been stronger to have a randomized control design, but that was not possible at the time due to resources or ethical aspects. Of why did you think about doing a randomized control design?
We did think about doing a randomized control design, but I think at that time we were trying so hard to get approval for additional funds to support that integrated care. And I think we just wanted to show outcomes data to administration so that they would support it. So like I said, it was pretty much, we were trying to synchronously start a new model of healthcare and gather data at the same time. So we just wanted quick data at that time.
Yeah, and I think that's it's good to have this exploratory data also before you go into investing the resources of having a randomized control trial, because this is really an area where we don't have a lot of data on how it affects patients to be more involved in palliative care, and it's not a lot of initiatives implemented either. We see it in the guidelines. We talk about it in state-of-the-art papers, but in clinical practice we don't really see a lot of services out there. So therefore I think this paper is important, even though it's a small pilot study. So can you say something about the outcome variables that you selected for the study?
So the outcome variables, we wanted to be simple. We wanted to get as much participation in a short period that we were collecting the data, which was 3 months. So we tried to really be parsimonious in selecting which outcomes would give us the most information or meaningful clinical data that we can have. So in this particular paper, we focused on 3 things. We focused on perceived control, and then we focused on patient activation as a way to operationalize self-management. And we also focus on symptom distress, because a majority of studies in palliative care emphasize symptom distress.
Yeah. And for those readers or participants that are not familiar with these instruments, could you say something about like the concepts, how it influences other outcomes, or why you selected these particular interests, questionnaires to measure the outcomes?
So perceived control was conceptualized as one's or a person's perceived influence over their outcomes or events in the environment. And it was measured utilizing a tool we frequently use in our research, in our heart failure research. And so we actually use the control attitude scale, the revised version, which is 8 items. The patients are asked to actually report on how much control they have over their heart condition. And so this tool is something we've used frequently in our research collaborations with heart failure team. So I wanted to use something that was a little bit familiar with what I've done in the past, so that if we had a chance to compare it against other cardiac populations, then I wanted to kind of have that option.
Yeah, and perceived control as a as a concept has also been found to be associated with quality of life and psychosocial, better psychosocial outcomes if you have a higher perceived control over your cardiac disease. So I think that was an interesting and important outcome to select with this type of intervention. It's likely that this is something you could influence.
And then for our second variable, which is patient activation. Now, I wanted to kind of explain that in patient activation here, we could have used a heart failure specific self-care tool, because there's a few that we've used in the past in our own research. But I was at this time working with a group of scholars at UCLA who were really supportive of trying to gather more data on the validity of this patient activation measure. And I kind of like the fact that self-care behavior tools in heart failure really focus on the behavior related to managing heart failure itself. Now, this patient activation tool extends beyond that, and it also looks at the patient's ability for self-advocacy, self-efficacy, and it also reflects their application of knowledge to maintain a satisfactory quality of life. So I like how this tool could be scored in such a way where you can put patients in groups of saying how much level of control they were at the time they completed the questionnaire. And then the last questionnaire we used was the Edmonton Symptom Burden Scale. And I used this because our palliative care specialists were really adamant that they're like, well, we have to match what we're doing with the oncology patients, and so we can have some reference as well in comparing the two groups. And so I agreed to use this particular general tool to measure symptom distress in lieu of using one of the heart failure specific measures that I've used in the past.
Yeah, I agree that was a good decision, because it also opens up, like you said, for comparisons with other diagnoses. And we also know, even though this was a fairly young population, we also know that a lot of heart failure patients also have other diseases that they have to self-manage. And so this gives a broader view of how active they were actually in their self-care and self-management. So and this scale was actually new to me, so it was exciting to do some background reading on that as well. And I think it's definitely an outcome variable or a measure that is interested and that has been even further validated after this study was published. You mentioned that you could have used a disease-specific heart failure self-management scale, but were there other outcomes that you wished you had when you did your analysis, or either to describe the sample or to correlate with the outcome variables you had, or to measure the effects of the intervention?
We actually reported on quality of life in a separate paper. So we did also look at quality of life using the Minnesota Living with Heart Failure. So the changes that we observed and reported in this paper were, were in the hypothesized direction, where those that had more palliative care or a palliative care consultation had better quality of life after 3 months.
Oh yeah. But you did not measure depression or symptoms of depression?
No, it got to the point where because some of the clinicians that I was working with were new to research, they were like, no, it needs to be something that the patients can complete in 10 minutes. I mean, I'm a researcher that's used to trying to give a lot of patient questionnaires, and it has worked previously in our heart transplant clinic, because they're used to having the researchers there But in this particular case, I think it was more the palliative care clinicians that were very, very conservative and wanted to limit the questionnaires.
Yeah, and I know that that is a strong argument within the area of palliative care research, that this is people or persons that are in the end of their life, and you should not tire them with endless packages of questionnaires. So I think that's a good point. However, having depressive symptoms, I think, would have added to your study, because it's been seen in other studies that, for example, being depressed might influence the uptake of an intervention that deals with how you manage your illness. So it would have been at least interesting to see, like, as a background variable.
What I was going to try to do is, because in the Edmonton symptom distress scale, one of the symptoms is depression. What I was going to try to do is analyze it as a single item. But when I read more into how that instrument was developed, no one actually has attempted to do that. So I decided, it's probably not going to be rigorous for me to do such a thing. I mean, we've come up in the past with a single item quality of life measure, and that has worked and it's been validated. But I guess I didn't find support in the literature to do this with that single item depression score. And so I kind of decided, in our replication study now, we are using the HADS instrument to measure depression and anxiety.
Yeah, I think that's good. But I see your point, and that's sometimes done, that you pull out a question and then say that this mirrors social support or this mirrors depression, and we can't really be sure about that. So I think that was a wise decision as well. California is a multicultural community, and there's a lot of focus on vulnerable populations and different racial groups and language groups to compare them. And you included patients that could speak Spanish or English.
We only included patients that could speak English because none of the tools that we had, except the perceived control, was already translated to Spanish.
Okay. So would it have been possible to provide the intervention in other languages? Did you have interpreters, or and of course, like you said, if you don't have the questionnaires validated in other languages, it is hard to involve other language groups.
And that's correct. So fortunately, the nurse practitioner, the single nurse practitioner that was working with us on the palliative care team, was bilingual. So she could have provided the palliative care services in Spanish. But if you consider the general population that's being seen at UCLA, it's also usually a higher socioeconomic group. And so they all did speak English. And I know because I was involved in consenting them in the hospital, because the School of Nursing was right beside the hospital. So it was easy when the physician would say, Lorraine, I have a patient going home, and I would go, and they all spoke English.
Yeah. And I think that's kind of a main problem that we have in many countries in nursing research, because language is such an important tool for us. We're just not drawing blood or scanning patients or taking images, but we're interacting, and the language is a tool both for giving the interventions and evaluating the interventions. So I think that we're missing out on a lot of people in Europe and the US and other parts of the world due to that we don't have instruments in all languages. We don't.
And I agree with that.
And it's hard. So I think that's maybe also something to for future research to test this kind of intervention in other both cultural and language groups.
And I think, I mean, building on what you just said, the limitation to collecting data in such a high socioeconomic group of patient in a single center is the fact that a lot of patients here, even in California, like you said, it's a melting pot. We can't generalize the data to that population because this was predominantly Caucasian, high socioeconomic status. all spoke English. So it would be nice in our replication study that's ongoing right now if we could try to capture more of the underrepresented minority groups.
Yeah. And you did some subgroup analysis on racial differences, and you found that people with African American and Hispanics had lower levels of perceived control and activation. Is that something found in other studies as well, or why do you think
it wasn't intentional that we were going to do the racial analysis, but when we did the bivariate analysis to look at the relationships between the outcomes of interest and the social demographic characteristics, I was very surprised to see that there were that race actually correlated with our outcome measures. So so yes, African Americans and Hispanic patients had lower perceived control. And yes, there are a few studies in heart failure that have confirmed the same findings. So it is definitely a patient population that we would need to help provide more services for, to try to engage them and empower them in their self-care.
Yeah, and going back to the aspect of improving or increasing the level of perceived control of your heart disease, what exactly in this intervention or the number of consultation that group that were kind of the intervention group received, what do you think in the intervention was likely, or what component, because you could see it as a complex intervention probably with a number of components, what do you think is most important for influencing, because you obviously had an impact on perceived control?
I wish I can parse out the component that was exactly the cause of improvements that we saw, but unfortunately, because we didn't standardize the intervention, we were just collecting the data based on the number of visits, but not necessarily looking at exactly what the patients were told. So at this point, we can only speculate that it was just the interaction per se with someone else that could listen to them that probably contributed to the improvements. Now, what we are doing in our current study, where we are trying to replicate, is that we actually have standardized how the palliative care consultations are being delivered, and we know exactly what the nurse practitioners are covering in terms of patient needs that come to the clinic. So at least this is what we've learned from this particular study, is how to proceed with trying to create an operations manual for how to deliver that palliative care integration into the heart failure care.
Yeah, and you also state in your findings that the levels of perceived control and patient activation were quite low at baseline. Are there cut-off scores, or what do you base that statement on?
There isn't officially, there is not, and I say this with confidence because the person who developed the control attitude scale, the revised version, is also one of my research collaborators, Deborah Moser. And I actually approached her when we were writing this paper to ask her about cutoff scores. And there hasn't been one determined. She says that it's something she would like to look into in the future. But when I said the fact that they were low, I was actually comparing it to the study where the tool was being validated, and they actually looked at 3 samples of patients, and this is almost 2,000 patients, where they looked at patients with coronary heart disease, patients with acute MI, and patients with heart failure, and they considered a median split of 28 as high versus low. So 28 was the cutoff in that particular study. So I think at baseline, our average perceived control was 25. So that's why I compared it to that big study of 2,000 patients, and that was all I had at that point to compare.
Yeah, and I think that even underlines that how important it is in this particular group to actually have an intervention that focus on increasing the level of perceived control, because I think that is associated with a number of other outcomes to influence.
And if you guys notice, the reason why I did like the patient activation tool is it did have cutoff points. So you had different levels of activation, and we were able to show a trend towards the number of people moving from level 1 and 2 to level 3 in the patients that got more palliative care services. And so we were able to document that trend.
So both having the perceived control and actually being more active in their care influences. So I think having no questions from listeners, I think that it's time to run up this discussion, and I want to thank you a lot for sharing your work and expertise and thoughts on this paper. And I think it's a very important area of research where it still are a lot of gaps in the knowledge. So I'm happy to hear that you also have ongoing research that are building on what you found in this study. And do you have any specific take-home message or other thoughts for the research area or for the take-home message for this paper in specific?
Okay. Well, thank you for having me again for this journal club. It's my pleasure to be here. I think the take-home message is pretty much the fact that there's still a lot of gaps in research. Trying to integrate palliative care with heart failure care is still in its infancy. There's still a lot of unanswered questions. A lot of times I get asked, so what are we supposed to include in the palliative care? And what I would like to see in the future is for us to be able to create like an algorithm where certain patients, based on the needs that they express they have, will get certain services. It's not kind of like a one-size-fits-all where we say, well, you all start with this and everyone gets this, even though they don't need it. Because as you can see, some of the patients are hospitalized, they get sick, they're hospitalized, but when they get home after we've treated them with medications, they feel that they're back to normal. They go back to work and they don't feel the need for palliative care. And I think if we were able to parse out a system, an algorithm where we can provide services only based on patient needs, and that would be like more ideal. And we would be able to tailor the intervention to the patient needs. So I think that's kind of the take-home message.
Yeah, and I agree with that we also maybe need to widen the definition of palliative care, at least on how we use it in heart failure care, because I think it's also a lot of clinicians that are struggling with which patients to refer for palliative care and what is palliative care and what are the needs of patients. So it's a very important area of research. Like you said, a lot of gaps in the evidence and gaps in knowledge, a lot of unmet patient needs. So from a clinical perspective, it's also very, very important research. So thank you once again, Lorraine, for being with us here today. And you can watch this conversation. It will be on YouTube, and you can contact the Journal Club email after, if you watch this session afterwards, to forward questions to Lorraine on this this publication. So thank you for listening and being with us, and bye.
Bye.